China related to this virus and the outbreak.
It no be one a photo, say we dey fight corona. But as we dey take precautions, I get the feeling, say we go overcome 'em.
It no be one a photo, say we dey fight corona. As we dey fight, we for pay attention, yeah.
Before you sanitizer, for once off a seminar, and regularly drink water.
If you coughing or sneezing, nose masks be the new anthem, my guy. Yes, I wear anthem.
Charlie, social distancing to the end.
Stay home be the best option, mini.
Exercise the body and eat healthy.
And at the end, we for pray to the Almighty.
Corona, I didn't be a banana, but we for take responsibility and keep fighting with positivity. Never spread calm, not fear.
Welcome, viewers, to another informative session of the Health Info Africa show. Today, we have a very packed session with a group of experts who are going to take us through a number of different topics. First, we'll be giving you updates on what's going on with the COVID-19 vaccines, and then we'll move on to talk about the impact that COVID-19 is having on our healthcare system. We'll also be talking about the COVID-19 numbers in Ghana and what they represent. And like I said, it's going to be a very, very informative session. I have with me my regular co-host, Dr. Edward. I also have two important guests with us who are all experts when it comes to public health. We have Dr. Pius Esando, who is a medical and public health practitioner and also a team leader at Medical Hub Ghana, which is one of the innovative and indigenous telemedicine companies in Ghana. And then we have Nana Kofi Kwache, who has been working with a number of institutions. He's a consultant, and then he's been dealing with the impact that COVID-19 has had on our healthcare system in the country. So along the line, these wonderful guests will introduce themselves to you in more detail, and then we'll have this beautiful discussion. So at this point, I'd like to bring on board my co-host, Dr. Edodofori, to share his opening remarks.
All right, so thank you very much, everyone that has tuned in at this point. We would like to thank you for sharing our feed, continue to share the feed and all the good things that we have for each one of you. Happy New Year. We're in a new year. We are hoping for better things to come. Today, we are privileged to have very, very powerful people that have a lot of knowledge to give us. And please don't touch that dial. Share the feed and make sure that everybody gets this information that we're about to share.
All right, thank you very much. At this point, I would like to bring in our panelists for today for them to give you a better introduction of themselves and what they do. So I want to begin with Dr. Pius Esando. Dr. Esando, can you hear me? Hello, can you hear me? Okay, so let me move on to Nana Kofi Kwache to tell us a bit about himself and then what he does.
All right, thank you, Daniel, and thanks to both of you for having me. Like I said, my name is Nana Kofi Kwache. I am a research fellow and doctoral candidate at New York University School of Global Public Health. My main research focuses on health systems and on health services, but well, actually, as a consequence of that, I had been studying over the last couple of years how financing mechanisms in Ghana affect healthcare delivery, specifically through the National Health Insurance Scheme. So as COVID-19 began to dominate the public health conversation, many of us in the field naturally began to look at it in our own context. And for me, it was really about looking at the question of how many cases can we have in Ghana before we have a critical problem when it comes to financing care for the people, care for survivors, and also dealing fundamentally with treatment for the ill in real time. And that led to me kind of, trying to get a hand on the numbers, trying to estimate when those endpoints would be with regards to health system critical points. And that's been a nearly 300-day long adventure now. So happy to be here, happy to share some of the insights I've garnered over the time.
I thank you very much. I think Dr. Pius Isando has joined us. Pius, can you hear me? Hello, can you hear me? Hello? Hello?
Hello.
Yes, we can
good
hear you.
evening to everyone, and thanks for the opportunity. I'm Dr. Pius Isando, a medical practitioner, a public health practitioner as well, and a health project management specialist. In the course of my work at teaching hospitals like the 37 Military Hospital, also worked at the General Hospital and many private facilities across Ghana. My specific area of expertise is in the area of health system strengthening, basically just putting in place interventions or adding on strategies to improve existing health systems, especially in developing countries. And today I'm here to share a few thoughts on COVID-19 and some innovative strategies that are being implemented currently. Thank you.
Right, thank you very much. As you can see, as we promised you, we have a very, very powerful lineup today. And as we usually do before we go on, would want to give an update of where we stand with COVID-19 vaccines currently. So I'll go on to do that before we go on to the other sessions. So currently, as it stands, we have 3 vaccines that have been approved for full use. There are others that are still coming in. And last week, what I did was to explain what the phases actually mean when it comes to vaccine clinical trials. So we tried to address some of the rumors that are making the rounds that these vaccines have actually been rushed in. And then last week, we explained what it actually means to go from phase 1, phase 2, phase 3, and to get approval. And I highlighted the other week that we have one that was actually abandoned. And I like to emphasize this to show you that in the case where something goes wrong in a trial, the whole trial is halted and everything is taken out of the system. So there's no need to worry about vaccines that have been approved. They are very well thoroughly studied. So as I indicated last week, in addition to the Pfizer and BioNTech vaccines, there's been another vaccine that has been approved in China. And this is from Sinopharm. And this has been used in a number of countries, including Bahrain. So now, moving on to talk about the numbers of people that have been vaccinated. Over the world, it's thought that about 10 million people have been vaccinated. China is ahead with 4.5 million, and the United States comes a second position with about 2.8 million vaccines. Now, there's a very interesting story with the United States vaccination process. Now, they were expecting to have been able to have vaccinated about 20 million people by the end of the year. But I mean, this is something that is new. We are faced with a new pandemic, new troubles. So this hasn't really been achieved. As it stands now, they have only vaccinated less than 3 million people. Now they are trying to work out to see how they can actually increase the numbers of people that they are vaccinating. The United Kingdom comes next. They have been using the Pfizer BioNTech vaccine. But there's some good news that has come out of the United Kingdom in that they have approved the AstraZeneca Oxford vaccine for use. Now, the exciting thing about this vaccine is that it has conditions for storage that are not as strict as are for the Pfizer BioNTech vaccine and then the Moderna vaccine. Now, these vaccines that are coming from the Oxford and AstraZeneca group can actually be stored at room temperature, in refrigerated conditions for up to 6 months. So that is something that is really, really wonderful. Last week, we talked about why the Pfizer BioNTech vaccine and then the Moderna vaccine can be challenging when it comes to our conditions in Ghana. But with the AstraZeneca Oxford vaccine, we can have better storage conditions for these. Now, last week, I showed that there were only a few countries that have been vaccinated so far, but we indicated that Germany was set to start their vaccinations on December 27th, and they did start together with a number of other European countries. And you can see that the numbers have increased as the days have gone by. So again, what are the side effects that people are typically seeing with these vaccines? And like we said last week, is the typical pain at the site of injection, some swelling, and then also the mild side effects such as the fevers. However, there have been just isolated cases of allergic reactions, but these are very, very, very minor. There was only one that has been reported here with the Moderna vaccine that was given to a nurse, and then she showed an allergic reaction. However, recovery has she's recovered. So again, there is nothing really to worry about when it comes to these vaccines. So this is the update I have for the vaccines as of now. And at this point, I would like to bring on my co-panelists to talk about what they also have to say about these vaccines that have been rolled out. So, Edward, do you have anything to add to what we've what? Can you hear me?
All right. Yeah, I can hear you, but I didn't hear the last part. But then I saw that you gave an update on the vaccines, and there's been a lot of talk about the safety level of this vaccine and what it's going to do to people when they do take it. There's been so many things that are circulating in the media, WhatsApp messages. This is the reason why we're here to kind of answer most of these questions. So if you have any questions that you want us to answer, please put it in the comment section. It's been great that we've added one more vaccine to the list. What that means is that at least people like Ghanaians can actually benefit from some of these vaccines. Because if you look at how many numbers in all these big countries, the chunk that they're taking out of the vaccines, it will be very difficult for Ghanaians to also have access to, or even other countries that are poor. So it's a good news that you reported today.
Yeah, and then before I go on to bring on the other panelists, I also want to indicate that the cost of the Oxford AstraZeneca vaccine is significantly lower than the cost for the Pfizer BioNTech and then the Moderna vaccines. It is thought that this is going to be about $3 to $4 per dose, whereas for the Moderna vaccine and the Pfizer BioNTech vaccine, we're looking at more than $20 per dose. So this is actually really fantastic news. At this point, I'd like to bring in Nana Kofi Kwachi to talk about or to add on to anything that he wants to share regarding the vaccines.
Sure. Yeah. I mean, like you said, I think it's really great that the Oxford AstraZeneca one has come online, and I think specifically for developing countries, we were facing a problem up until that happened where the most promising vaccine candidates, the mRNA vaccines that have really dominated much of the development process so far, much of the news cycle, where those have to be stored at temperatures that are well outside of the typical vaccine cold chain that we use for other things that we do in Ghana, in Africa generally, and really many other parts of the developing world. And that was creating a scenario where if Oxford AstraZeneca couldn't get the kind of efficacy that they eventually got, countries like Ghana would have been looking at well into 2023 before the kind of supply chain dynamics that exist for the other ones would play in our favor. And quite obviously, if you look at the difficulty that a lot of developing countries have in the choice between a quick end to the pandemic or putting in place, long-term economic measures and public health measures to stave off that point, it's quite clear that the sooner we can get a vaccine, the better, because the expectation that the public health measures will be able to hold for another year, given the economic consequences and given really the lack of political will to really follow through on them, this really is a godsend. So the prayer is that we can see more of the data that they use in those studies, because there is some a bit of consternation that we haven't seen as much data come up out of that trial as we saw coming out of Moderna or out of Pfizer. So we're hoping to see more of the data. We're hoping to see more of the data also around who the actual, sample, like the actual test subjects were, because it looks like the Oxford AstraZeneca trial skews a little younger than Moderna and Pfizer, which in our case in Africa, for example, shouldn't be that big of a problem. But I do think that's important just for confidence, for us to see more data. But those three vaccines right now, all very promising, and are all going to be really critical in making sure that we can see an early end to, this awful pandemic.
Yes. So thank you very much. Yeah. So yeah, it's really promising news. Pius, Dr. Sando, is there anything you want to add to the discussion so far?
Yeah, Daniel. I think since the advent of this disease, countries have adopted several strategies to try and curb it. Some countries had attempted herd immunity, like the UK, with the intent that eventually, as the disease unfolds and they have majority of the citizenry being infected, it will automatically confer some level of immunity among the general population. But clearly, this has failed. All countries that were looking at this approach have come to the realization that herd immunity is not the solution as far as COVID-19 pandemic is concerned. And it's therefore important that we look at strategies that will be effective. Me, the biggest and most important strategy going forward in the fight against COVID-19 is definitely the rolling out of the vaccines. And it's incredible news that so far this has been started in the US, the UK, and some of the developing countries where the disease is being most devastating. And for us in the developing country, we should also be happy that this vaccine is actually out. And with the introduction of many more candidate vaccines, then there's the potential that we also get vaccines in our countries to curb this disease. But we have to prepare ourselves in readiness for the introduction of the vaccine. And that's the area of much concern to me. What are we doing before the vaccine actually comes into our country? Are we doing the necessary education? Are we trying to get the citizenry very much involved? Are we using our local languages to get our people very well informed? We know when Ebola reared its ugly head in Africa, and there was even the attempt to set up a research center in Ghana, we know the kind of confrontations that we had and the way people openly didn't want this center to be established here. So the question would be, are our people really ready at this point to accept the vaccine, taking into notice all the conspiracies and all the messages being shared on social media platforms and all that? So I think the time is now. The Ghana Health Service has indicated sometime very early this year, maybe in the first or the second quarter, Ghana would probably have its first consignment. And I think the time to start the education is now. We should have the media, we should have all leading public health experts coming to the table and the necessary education done so that our people will take this vaccine fully assured of its effectiveness and fully assured that it's safe. I think those would be my comments as far as the things are concerned.
Yes, and you said it rightly. I mean, the public education is very crucial. I mean, there's a lot of misinformation, disinformation currently going on with the vaccine. Now, this hasn't been new. I mean, COVID-19 we know has been, it's more like gone hand in hand with misinformation and disinformation. The conspiracy theories, I think, are even more than the facts that are out there. So yes, we need to, I mean, educate our folk back home, and that is why we are really grateful that you all have joined us to help us bring the right information to our guests. So at this point, I would want us to, I mean, shift into what the numbers actually are in Ghana. It appears that COVID-19 has affected mostly the developing world when it comes to mortality. But what do the numbers actually say when it comes to Ghana? Have we been spared that much? Are there any consequences we are going to face later? These are very interesting conversations that we need to have, because it could have a lasting impact on our healthcare system. And this is where Nana Kofi Kwache's experience and expertise comes in. And I'd want him to lead this part of the conversation, or to take on this part of the conversation when it comes to what the numbers represent in Ghana, what they actually mean, and then where we're actually heading. So, Nana Kofi Kwache, yeah.
Okay, thank you, Daniel. Okay, so I want to start by looking at what the numbers that Ghana Health Service actually puts out, what they say. And I want to work back from there to look at what that means in context, and then what that also means for the rest of our fight going forward. I think, first of all, it's important to caveat the Ghana Health Service numbers with the recent study by the West African Center for the Biology of Infectious Pathogens and Noguchi, who together had been conducting a seroprevalence study which is basically an effort to identify what proportion of the population in Accra and its suburbs actually had antibodies for COVID-19. Now, if you have antibodies for COVID-19, the expectation that you've previously infected. And their estimates would suggest that about 20% of people in Accra and Kaswa have previously been infected with COVID-19. That was for a sample period that lasted from late July all the way up to early September. And what that translates to in numbers is actually about 1.2 million people. So you put that in context and you look at also the question of how people behave and how low compliance has been. And that appears to be a much more representative picture of what's going on in the country than what we have from Ghana Health Service. But I will walk through the Ghana Health Service data to point out certain trends and also so we can understand how the management has changed over time and what we should understand from that about where we are in Ghana right now. So in the most recent update, we passed about 55,000 cases. We're about 55,064. That still has us at a generally high level for Africa. Most of the African countries are still about below 25,000. But Ghana, South Africa, Morocco, Egypt, and a few others are really driving the numbers around the continent, with Ghana really being, for the most part, the driver of the West African epidemic or pandemic. But again, important to acknowledge the fact there that Ghana is testing at a much higher rate per capita, or was testing at a much higher rate per capita than the rest of our neighbors. But if you look right now at the public health response aspect of it, we know that the foundation of that really is a test and trace strategy. And if Dr. Fossa will put up that slide again, actually I can start from there and point out a few things. So the idea behind the testing really in Ghana, right from, actually if you go to the next slide, actually, I think I can start from there instead. I put them out of order. Thank you. So the testing in Ghana really, for a very long time, consisted of tests for symptomatic cases at hospitals, and then tests for the contact of those symptomatic cases. And in this graph here, the hospital tests are in red, the contact tracing tests are in green. And you can see that for really up until September 1st, those were really that's all we're really doing. So people coming to hospital saying they were sick, and then some amount of community-based screening and contact tracing, which you have in green. What you can see for both of those is that pretty much first in late July for the hospital testing, you start to see a sudden decline there, which comes about when the Ghana Health Service sends out a directorate requiring healthcare practitioners to change the case definition of a suspected case, and then also to test only symptomatic cases that met certain standards of that definition. And that began to see the hospital cases going down. And as the hospital cases were going down, because that was the real seeding pool for the contact tracing, after that backlog of tests for contact tracing was done, you start seeing that decline as well. And that has declined steadily all the way from late August, to the point where now, on a good day, we are doing about 1,000 tests a day. And that's down about 75% from what we're doing in the June-July window. Now, what that means practically is that we are now doing, in some cases, more tests per day at Kutuka, which we started doing in September, than we are doing at all the hospitals in Ghana combined, and for all the contacts of all the sick people we know combined as well. And that's what you see with the blue bars over there, where you see that on any given day we are testing significantly more at Kutuka than the rest of the country. Now, if you go back to the previous slide, I can show you the actual percentage shares and how that's changed. So yeah, so you can see how up to September 1st, hospital and contact tracing, it wasn't just that they were the main share, but they were also being done at a very high level, or a relatively higher level than we're doing now. After September 1st, you begin to see, a steady decline again in the percentage of tests that come from hospitals and from contact tracing. What that means for us really, when we have testing that low, is that it shows kind of what the focus is, which is that we are really going back to this narrative about imported cases. And we've heard that sometimes in November and December from the Ghana Health Service, who said that the reason why we're seeing the resurgence, quote unquote, in cases in Ghana is because of the opening of the airport and tests of arriving passengers. But it's important to understand that that is not necessarily accurate. We know that from WACBIP, we still have a lot of virus in circulation. We know that we are not testing at any significant level in terms of in the community to detect that. And at the hospitals too, by virtue of stigma, by virtue of poor risk communication, by virtue of the cost of testing, after the withdrawal of free testing by the Ghana Health Service in a lot of places, the demand has also gone down. So what we are seeing from the Ghana Health Service is really, a snowflake on the tip of an iceberg, because it's just not representative of what's going on, on the ground in terms of its scale, and in terms of what inference you can make from that. Now you can also look at some of the other measures that we're seeing from the testing we're doing. One of them called the positivity rate. I think we can go to slide 3. So this is looking at the positivity rate all the way from May 1st to December 24th. And what the positivity rate really is a measure of, let's say every 100 people we test, how many of them are actually going to be positive. Now, the WHO basically gives us a safe zone, which is 5%. So if we test 100 people and we find 5 of them or less having coronavirus, then we know we have a low enough level of circulation in our society that we can consider doing certain things. I like to think of that doing certain things as a risk budget, where your testing, your tracing efforts, the amount of virus you have in circulation, all those things allow you to estimate the effectiveness of your public health response. Now, what you spend that risk budget on is things like opening schools or opening entertainment centers or opening markets, the things that are essential to life and the things that are necessary for comfort. Those are things you spend the risk budget on. But if you look at where Ghana has been all the way from May 1st to December 24th, there have been very few times we've actually, whether for hospital testing or contact tracing, been in that safe zone where we could have been doing the things we said are safe to do. If we think back to June 15, for example, where the Ghana Health Service and Ghana Education Service decided that they were going to reopen schools for final year students, also around the time where the voter registration actually began, what you see in the positivity rate is a rise from somewhere around 7 or 8% in late June. That then continues to as high as 30% in August. When we hit 30% positivity rate in our hospital testing in August, that would have put us where places like Bergamo in Italy, where at the start of the pandemic in March and April, which saw calamitous results for the healthcare system, it actually put us throughout the month of August in the top 15 countries in the world for positivity rates. That makes a lot of sense when you put it together with what WACBIP found, because what that number suggests is that really all the way from June to August, we had explosive, uncontrolled community spread. And we even saw that, translate into infections at the seat of government, into the deaths of prominent political leaders. And then you have a period right after that where you see that sudden decline. That sudden decline corresponds with the change in the testing definitions. It corresponds with the changes in pricing and costing of the tests, where a different kind of person starts to test. And that kind of person who starts to test is the kind of person who's about to travel, people who generally had not had, the same kind of average risk as the rest of the population. Because even the WACBIP study, what they found was that for people who fit proxies of high income, the percentage of them who actually were infected was much lower, it's about 15%. Whereas for people who fit the lower or middle income categories using the proxy they had in the study, the infection rates were actually about 22 to 27%, depending on which. So that sudden decline you see in the positivity rate reflects that shift towards a different kind of person. And that kind of continued for a while until, people started arriving in the country again. We began to increase community-based testing again. And that's when we started seeing the bit of an uptick in positivity rates again, right from late November through December. But again, what is obvious from the graph here on the screen is that if 5% is supposed to be safety, then there really hasn't been a period really since early May where we've been consistently under that zone. And if you compare that to how the narrative of what's happening in Ghana is, it seems a little bit discordant, because what we've been hearing is, Ghana is on top of it, we are managing the pandemic, but the practical questions of even what the Ghana Health Service is putting out in terms of its own data suggest that when we were opening schools, when we were doing voter registration, when we're saying that it was safe to begin the easing, throughout that period, we're higher than we should have been in positivity rates, and we're still that the decisions we made then resulted in a steady increase until we're in the top 15 in the world. And what the WACBIP study shows is the consequences of those decisions. And so the question we have now in Ghana as a function of our testing and our tracing and everything is really about what is the state of the pandemic. And where we are really is in a place where we don't know. That's the truth, because we're not testing enough to have any representative data on positivity rates. We don't know the level of community transmission. We are not testing. There are too many financial barriers in terms of also individual, self-demand testing that are also causing quite a few challenges. And then there's also the requirements by Ghana Health Service on public institutions to meet certain criteria before they can do any other kind of free testing that comes with diagnostics. So all that together, coming up with a firm conclusion that we know where we are, not possible. But if we look at the proxies of where we could be, that is to say, what is actually going on with the things that prevent massive spread? What's going on with physical distancing right now in Accra? And I'm sure, as most of you know, clubs and bars are actually open, contrary to what the president has said. Beaches are open, entertainment centers are open. The only thing I've noticed that are still closed really are the cinemas. Other than that, Accra is back to normal. You look at hand washing in that context. This morning I got a haircut, and at some point I was wearing my face mask. The barber asked me to take it off, because he wanted to do the fade on the side. And when I just took off the straps, he was like, "Oh, you need not perform." And I was like, "No, we have very close contact. There are people in there who are wearing masks." And the whole kind of vibe that I got in that experience was something you get often in Accra, where it's like, if you are wearing a mask and asking people to keep a distance, if you don't shake hands, you are being extra, you are being rude. That's kind of where the social dynamic has turned to as well. And that's also telling. Then you look at the question of whether or not people are aware in terms of risk perception. And you have increasingly this narrative that says that, COVID is not that bad in Ghana. And that has become kind of a dominant narrative. But if you actually take your time to listen to the experience of people who have had COVID, even mildly in Ghana, some of the prominent people, Gary Al Smith, Kojo Youngson on Joy FM, they all talk about how they are still experiencing symptoms of fatigue. They're having headaches. They're having difficulties after that. And that binary live or die thing that we've kind of formed around COVID in Ghana is also not helping us in terms of people's understanding of where we are and what they have to do. And when you put all that together, you have a situation where those of us who are crunching numbers are doing risk assessment to understand where we are. But the public narratives coming from the Ghana Health Service, coming from the Office of the President, coming from, also what people are seeing in terms of what they're seeing friends do, what they're seeing their churches do, is changing risk perception. And risk perception in Ghana is plummeting, where people do not really believe that COVID-19 is that bad. Frankly, it wasn't until fairly recently, I think, with the December crowd, where a lot of people have gotten infected and have gone to test, and they are coming with a different kind of like financial profile, different kind of health risk awareness, and that's what's showing up in terms of people's renewed awareness about what's going on, which is a good thing short term. But when you think about what a public health response is supposed to be, where we're supposed to be taking behavioral variables and factoring that into a public health response, those variables are telling us that we're in big trouble and the response is saying that those variables don't matter. If you look at actually how we are reacting to those.
Yeah.
So we're not in a good place. We don't know how bad it is, but we are definitely not in a good place. The hope is that Ghana Health Service will focus on the important things right now. Like we said already, we're not, the Ghana Health Service came out and said we're going to have a vaccine in Ghana by March 2021, which is 90 days or so from now. The truth is that that's not going to happen. We have, like Ghana is one of the 6-7 countries relying on COVAX to get a vaccine. And COVAX is only supposed to cover 20% of your population. And of that whole population, 10% of them are actually going to be vaccinated this year. So the end point for us in terms of public health response is still 12 to 18 months away. So the vaccine is a good thing, but we have to reorient our minds around what that actually means for Ghana, because in 2021, it doesn't mean anything for us. What it means really is that we have to double our efforts on the public health measures. And that requires political will, that requires intellectual honesty, that requires candor, that requires folks who are in positions where they are seeing what all the rest of us who are experts and public health professionals and clinicians like Dr. Sando are seeing, and what they are saying. That has to be taken seriously. And there has to be a better concerted effort to require accountability if that doesn't happen, because the consequences for the healthcare system are going to be dire.
Yeah.
People are going to have long COVID. We don't know how well that's going to go for a lot of people, because we're still learning about that. And if we're not able to do the simple things, getting a COVID-19 patient registry, making sure, like Dr. Sanders said, we're doing effective health education and community engagement on risk around the vaccine and on the public health measures, we're going to continue down a road that I don't think is really helpful for our long-term health profile as a country, and which our long-term healthcare planning cannot support for the consequences that will bring. But that's kind of my view of where we are right now. That's my view of what the critical data points are telling us. I have a few other slides in there that show what's going on with the arrivals as well. If we go to the next one, I can point that out. I just want to go through this one quickly, just to show that also when we say that, the reason why we are seeing more cases, and one of the other things about responsiveness in the pandemic, when we say we're seeing more cases at Kotoka because we are getting more arrivals, that too is not true. Here's a positivity rate for Kotoka itself. Yes, it's under 5%, which is good, but you can see quite clearly that all the way from when we opened the airport in September, it has been increasingly more likely that arrivals will be infected. And what have we done at the airport about that? Have we instituted a quarantine to accommodate that? Have we instituted maybe even country-specific quarantines based on what we're finding out about the new strain in the UK or in the one in South Africa? We haven't done any of that. So again, if you look at the data and what we are doing, there's no relationship between what the data is telling us, what the public health response is, and then what the narrative about what the public health response is. Those are three absolutely different things. And you see in my last slide also some of the reasons why some of us are concerned about some of the data we're getting from Ghana Health Service. One of the categories of the testing that goes on there is called routine surveillance, which is what happens. That's people walking to a hospital and getting tested. And what you see in routine surveillance, if you think about it, supposed to be people who are sick at home, randomly coming in and saying, Dr. Mebowa, Mitia Miya, that kind of thing, and then getting a test done. So unless you have a cap or a quota for that testing, the number should always be kind of random because it varies by people who are coming in. So when you look at from December 6th to December 22nd, you see sometimes 500 tests repeated twice, happening in 2 consecutive days. What the suggestion there is that randomly, twice in a row, in this case, 3 times in 21 days, randomly, 500 people exactly came and got tested at hospitals all over Ghana. What's the likelihood that that's the reality? And especially when you look at that number, you see 400 repeated 3 times, 450 repeated 3 times, 500 repeated 3 times. You start to wonder about the validity and the accuracy of the data we are getting, because you ask about quota, you ask about all that stuff, and it doesn't seem like there is one. So how you get numbers like this also becomes a bit challenging. But that's kind of where we are right now, a situation where we have to reconnect the data to the public health response and relate those two things back to what we are saying. Otherwise, we're not going to be successful at convincing people there's a problem or getting public buy-in into solving it.
Right. Yeah, so that's a really good description of how the situation is on the ground, and it's quite worrying. I'd want to go to Dr. Sando for a few words on this if he has anything to share. Pius, can you do you have any comments to add to what Nana Kofi has said?
I think Nana has simply dealt with the topic. Just putting it all together, the situation that seems to be presented to the nation actually may reflect the tip of the iceberg. Whilst the Ghana Health Service statistics that are produced seem to provide an idea of an assuring situation, it actually may not be that situation. Like indicated, currently we are doing very low testing. Our test numbers are as what we had in July and August. All right, and even the tests that have been done reflect cases that have been imported. There are tests that have been done at the ports of entry. They are mainly the airports, and also tests that have been done for people who want to leave the country for one reason or the other. But let's keep it at the back of our mind that community infection is on the rise. We are encountering many patients who come to our outpatients with complaints of loss of smell, loss of taste, much more frequently than we had in the past. And if all these cases, we still have the rigid testing system and all these people would be tested, I'm sure we'd be having very high numbers in terms of cases reported. Again, our contact tracing system has broken down. Ghana actually was commended for being one of the few countries that was having an aggressive contact tracing, where we're actually moving beyond the index cases and going to the communities to find their contacts. But this has broken down. Since about September, we are not aggressively doing that. And I recall in the peak of the moment around August, June, like in my neighborhood, when someone tested positive, we had contact tracers from Ghana Health Service coming around, actually testing everybody within a certain radius. But we are not seeing this. And generally with the population, it looks like life has returned to normalcy. So during this Christmas, you go here and there's a party, everywhere there's a social event. We shouldn't forget the electioneering period, all the rallies that were held as if COVID doesn't exist in Ghana. So in actual fact, we probably are living on a false sense of security. What's may be going on and the actual figures may be different actually from what is officially being presented to us. And we expect the media and community partners also be involved in this fight. You would realize that the media has also moved on to more sensational news and coverage of the elections and then even the post-election issues that are coming up. Fine, those are national issues, border on security and everything, but I think there should be dedicated time to actually talk about COVID-19, draw the attention of people to the fact that the disease is still here with us, and if we all don't change, it's going to be here with us for a very long period. So I think we all have to change our ways, and the media should also be very credible partners in this. They should contribute immensely. Let's push information on COVID-19 out. Now you move around, you talk to people, nobody is wearing the mask. When you talk to people, people say now it's not there. The disease is no more there. That's the picture that people are having, but that's not the reality. We are having people dying silently from the disease. We are having people getting the disease, being asymptomatic, and some also having symptoms but recovering. And every single individual who has it has the potential of spreading it to hundreds and thousands of people. So we have to up our game, knowing very well that we've had so many public gatherings during the electioneering period, during the Christmas festivities and everything. We should, it's time we take a critical look at this disease again and change our attitudes.
Yeah. Before we move on to another, you mentioned something, and And that is one excuse you find people on the ground given, that, oh, people are not dying, because they see the numbers. They see the numbers in the United States. It's about 2,500 dying a day, and then you go to GHS and they are reporting just few deaths. So what do you have to say to this? Because it appears to a lot of people that is what is going to be a deterrent to them. They feel like they get it, they recover, they move on. I mean, you also mentioned the long haulers. It appears that is not even discussed in Ghana, but that's a really serious issue. We should be talking about people who have actually gotten infected and then are suffering from complications. I mean, I saw a report today where somebody was having something relating to psychosis following, I mean, even recovering from COVID-19. So what do you have to say about what people say with the low deaths and all that? Do you have any comments on that? Dr. Sandra, I want to start with you.
Okay, so I would say truly the virus has behaved a little differently in our context compared to the developed countries. Probably our temperature, the fact that we are in the temperature region, the temperatures and everything have contributed to this development. But let's not use that as a reason to downplay this virus. The virus has the propensity to behave in a different fashion. It has the propensity that we are recording. Let's also note that, like we've indicated, we actually are not aggressively testing now. There is the potential that we are making a lot more deaths, especially in the rural areas.
Hello? Hello?
I think we lost him. So yeah, we can continue the conversation. Yeah.
Can I jump in on that actually?
Kofi, go on.
So on that question, right, of the even the data, right, of what it actually tells us, I think it's quite obvious, like Dr. Sanders said, that the actual disease trajectory in Ghana has been different from what we've seen elsewhere. But I look at it and I always say, let's look also what the data tells us about that, right? You look at a country like Italy, even in the height of the epidemic, a very, very small percentage of all the deaths were happening in people under 65. And in Ghana, I mean, our average life expectancy is not even that high. So you have a country where the average age is 21 in Ghana, it's 19 in Nigeria, it's about average 20 for West Africa. So it's unsurprising that if you can have a lot of infections because people are much more mobile and much more engaged, and have better outcomes because the people are generally younger, they're generally healthier. So you in terms of deaths, it shouldn't be surprising to us to see that. But even there, right, we are still seeing a lot of young people. The Ghana Health Service own data. If you analyze it and look at when they were still putting out the demographics of the disease, their age, their death, their age and gender especially, we saw a case where there was actually a higher proportion of younger people dying in Ghana than it was on average. So that's something we saw for a fact. We also know that Ghana Health Service, unlike a country like South Africa, is not doing an excess mortality study. And excess mortality in our case really matters because South Africa, for example, went and did an excess mortality study and found out that COVID deaths were twice what they thought it was. Russia did a similar thing and found out that it was 3 times what it was there. And these are countries that have generally good surveillance for that kind of thing. Ghana only records 20% of deaths that happen every year officially. Only 20% of deaths that happen are given an official cause of death, full autopsy, all that stuff. So we know that's a problem we have already in terms of data collection. So how would do even a excess mortality study? That's going to be a challenge. But then you look at the actual data we're also getting on the deaths. I mean, Manasseh Azuri wrote an article in August where he pointed out that at the time there was some disparities between the regional data that was being put out by the regional directorates for deaths and what the national data was saying. That was because of a delay that I'd also been tracking for a couple of weeks at that point, where sometimes the delay between when a death would happen and when it would be officially announced or counted in the deaths in Ghana could be as long as 3 months in certain cases. And we're seeing an average delay of 58 days in August. So we've asked questions about, was that because of a backlog for auditing or review? Does that backlog exist? How many people on that backlog? We're not getting those answers there too. So it is a good thing that obviously we've had so many fewer deaths than the rest of the world, but exactly how few, I think that's still something where we are understanding. But unfortunately, the way that is being communicated doesn't acknowledge that fact that that 336 that we have right now is not the full picture. It's not even the full picture of what the Ghana Health Service knows. So there is an issue there as well. But it is critically important we figure out a way to get past that block, because if people continue to think that it's a binary of die or like live or die, and not long COVID, not long-term health effects, not long-term economic effects, we're going to have a big problem on our hands.
Yeah, so that begs the question that are we kind of prepared for what is going to happen? Because we know that these things you're talking about is not looking good going in the future. Does Ghana have the capability to handle like a lot of ICU cases or something like that?
I think so. In March, when the pandemic began, I know Ghana at that time had about 80 ventilators available. I think that number is probably somewhere in the region of 120, 130 right now. Ghana Health Services, if you include private hospitals and everything, it probably gets close to 200. But we're in a country where, when I was doing the math in terms of our physician capacity, acute care capacity, if we assume that all our healthcare professionals were all on duty at the same time, managing all COVID-19 cases, our limit for where we'd be in trouble was 8,000, and the limit for 8,000 cases, active cases. And our limit for when we'd be in health system distress was about 14,000 active cases. So it was. I always thought it was very interesting. We hit 13,856, and then we did the change in definition of active cases. That saw us come down to 3,000 overnight. But what also that came with was shifting all the care to the homes, and you see that kind of thing going on. But I think if you're looking at a country that's planning long term for what COVID could mean, one of the bare minimum things you have to have is a patient registry, where you are managing, you are collecting symptoms, you are interviewing people. It's a full data collection study, and we're not doing that right now in any meaningful way. So even there, I'm not sure we are preparing or prepared to really deal with the long-term consequences we're facing now.
Okay, let's jump to Facebook real quick and pick up some questions, and then we'll come back and continue the conversation. So we do have Wisdom says, if Ghana had a high positivity rate of approximately 30%, similar to that of Italy, what explains the low mortality rate in Ghana compared to Italy? That is a question coming from Wisdom. So do you have anything to add on to that?
So I think that's one of the questions that, if you listen to people like Professor Gordon Awandari at WACBID, Dr. Holu at Noguchi, all of them are really now talking about the fact that we need to focus on research, because the truth is that we don't know why. We know that has happened, but we don't actually understand why. Could it be about a local strain? We're lucky that WACBID has been independently sequencing that with Noguchi to keep an eye on what's going on there. Could it be about the age demographic thing we were discussing earlier? Could it be a seasonal effect? Could it be a hangover, like a residual, or previous exposure or immune training from other coronaviruses? We don't know. And but of all the things it could be, if you like, I think it's those are the things that we should focus on. I frankly don't think that. And I've been on a show where this debate came up, where it was like, is it because of effectiveness of government interventions? And I wouldn't rule that out, but the measure of government interventions is whether or not, when you say clubs are closed, they're actually closed, and we know how that's going. So I think in Ghana, it's going to be a question of those kind of either biological or genetic factors or demographic factors that are really swaying it for us. But the truth right now is that there's no empirically studied answer. So it's all just conjecture right now. But those are things that seem feasible.
All right, great. And then there's another one coming from our YouTube channel. Person's name is Essie Hereford. She says, I agree with Dr. Pius. What's being reported is not true reflection of what is happening on the grounds. It is almost as if COVID is a thing of the past. Thank you very much for your comments coming in. And also we have Eunice bringing in something. She says, I agree with Dr. Sander about the false sense of security with COVID-19 in Ghana. Thank you very much. And she also says, good question. We have Ms. Hayford saying that, wow, psychosis. I think we mentioned something about psychosis. Eunice again says, hospitals in the United States are high alert for the new, more contagious COVID-19 strain that have first surfaced in the UK and has since shown up in Colorado, California, now in Florida. Has Ghana seen any of these cases? We're going to pause on the questions right there and answer them.
So as far as that question, I think that's a really good question. I think something that we're all very interested and concerned about, but I don't know what Dr. Sando and Co are seeing in the ward in terms of whether there's a change in the clinical profile, but I know that the folks at WAGBIP definitely are very interested and are paying attention. I've had some conversations with some of them even about the South Africa strain, which in my view, like as a scientist, I think that's actually much more concerning than the UK one, because the UK one is more transmissible by about 50%. The South Africa strain is more transmissible by about 70%, it looks like. And the problem with the South Africa strain is also that it's still anecdotal, but doctors in South Africa are already saying that they're seeing a younger share of the hospital cases a bigger share of the hospital cases over time coming from young, healthy people with no pre-existing conditions. That combination is a nightmare scenario. So I don't know whether we're beginning to see that shift here. But I know, for example, in my own circles, I'd say my inner circle and the outer circle, this has been a very difficult last 2 weeks. There's been a lot of infections there. I've been tested 3 times because of that these last 3 weeks, where, right. I mean, I very rarely go out, very rarely do anything, but you see people 2 days later, you get they're sick, it's quite a problem. But I don't know whether the clinical profile is changing.
All right, so Dr. Sando, yeah, okay. Yeah, I was going to ask Dr. Sander to add anything if you have seen anything like that.
Yeah.
Okay, so in terms of clinical presentation, we are not seeing any difference to suggest that maybe there's a different strain that is causing current disease. But I think this is where we have to up our game as far as research is concerned. When we take WAGBIP, when we take Noguchi, they have the capacity to actually try and subtype, isolate new strains, and therefore help us in our interventions. I think that actually is beyond clinical practice, but more into those who do molecular research. And therefore, I will treat WAGBIP, which in the initial stages, even to do some subcultures of some of the coronavirus that we have in the domain of the research institutions, Noguchi and WAGBIP. Yeah, but clinically, we don't have any evidence to suggest that we are seeing a newer strain.
All right.
Can you hear me?
Yeah.
I'd want to switch this discussion slightly to what impact COVID-19 is having on our healthcare system. I mean, up to this point, we've only talked about COVID-19, but it's over here. It was in the United States. It was even the case where people were seeing low hospital attendance when COVID-19 was at its peak. And this is even a place where the healthcare system has a higher capacity compared to what we have in Ghana. So I just want to ask, what has been the impact of COVID-19 on other, cases when it comes to health in Ghana? Dr. Isando, would you want to take this one?
Okay, yeah. So Daniel, thanks for the opportunity. First, it is interesting that compared to the developed countries, we are not seeing as much mortalities, but we need to situate it in our health system. First, we should understand that even before the introduction of COVID-19 into our borders, we had existing health system challenges. Some of these, which I'll just touch on briefly, are the fact that we have limited infrastructure across many facilities that we have, both at the primary level, secondary, and tertiary level. So even at our leading facilities like Kolebu, we still have challenges as far as physical infrastructure is concerned. Likewise, we've had a perennial problem with availability of equipment, lab equipment, diagnostic equipment, CT scans, MRIs. We know of traditionally having a problem with bed capacity in our facilities. So we have the low bed syndrome, which has characterized our health system. Also, we have the low doctor to patient ratio, with one doctor sometimes serving as many as 10,000 plus people. These are problems that have bedeviled our health system over the years. And COVID-19 has brought in other pressing challenges that I will briefly touch on. And I've characterized them into two broad categories. We have institutional challenges, and then we have human resource related challenges. With the institutional challenges, some of the problems that we've had, especially during the peak of the disease when we're testing more, June, July, we realized a reduction in OPD attendance. This is natural and it's happened almost globally. Patients are anxious about the disease. They feel like maybe when they go to the hospitals, they are likely to contract the disease and therefore do not come at all. And also, we have our OPDs traditionally being congested so that the needed physical and social distancing protocols are difficult to adhere to. So, for instance, in Komfanoche Teaching Hospital, during the peak of the disease, the OPD at a point was closed to avoid people coming together and crowding and many people contracting the disease. Again, we've seen an effect on special clinics. We have diabetes clinics, we have hypertension clinics, where we have otherwise stable patients who come for routine visits, are given their medications, and they go back. But because of COVID and the fear and anxiety amongst all these patients, we saw a reduction in attendance of these special clinics. And now moving on to special services like antenatal visits. Even around that time, there was a slight decline in antenatal visits as well. Likewise, in child welfare clinics and in immunization coverage, Ghana Health Service records show a significant decrease in patronage of these services within the months of around May to August, possibly due to COVID-19. When you take family planning as well, we've seen a decline in uptake of services, and the effect of this could lead to increased abortions in the very near future. We could also have population boom because we are trying to discourage people from going out unnecessarily. People are staying at home. Naturally, sexual activities are likely to be on the increase, and we could have a number of babies coming up more than expected in the next couple of months. And what this would do would be an effect on social amenities and development of the country as a whole. We've also seen people not presenting themselves for their annual medical screenings. Like, people would typically come in, maybe I want to be sure that I'm fit, just come in, run a number of laps and all that. But this is not happening as much as before. And then there are other issues that we need to take notice of. There's been a surge or balloon in the use of antibiotics without prescription. So people are self-medicating. And a personal experience around July, when I needed Citromax actually for a patient, running around a couple of very top pharmacies in Accra, it was very difficult to lay hands on it. And from all the pharmacists, people were just purchasing it without prescription and everything. So one problem we could have in the very near future is antibiotic resistance, and I presume it's already on the rise. We also have seen an indirect increase in emergency cases. For instance, people would have come for their BP checks, sugar checks. We are not seeing this. They'll be at home, probably not taking their medications, and then they could have an hypertensive or diabetic emergency and present at our emergencies. These are some of the institutional impact that we are seeing. as a result of this disease. And this is also even worsened by the fact that we do not have emergency and life-saving equipment in quantities as expected. For instance, the ventilators that we have very few ventilators in the country. I happen to be in Regional Hospital, which had 3 ventilators. And all these 3 ventilators were for use of people who did not have COVID. So the question would be, what happens if someone had COVID and came in and needed a ventilator, and they couldn't move the person also to the ICU, because that's where all the other people with other conditions would be. So these are the challenges that we are having. In terms of human resource related challenges, we've realized from the onset of this disease our failure to invest in some category of healthcare providers. And we don't have disease specialists. There are very few in the country. Emergency physicians are also not as many as you need to cover the street hospitals and the peripheries. And then at the onset, we had issues with PPE availability. So health workers were not getting the required PPEs, especially the N95 and the protective gowns. But over time, that was addressed to some extent by government. And I'm hoping that since we invested in some local companies to produce this, we will not lose sight of the fact that we have to strengthen their capacity to provide this, because for all indications, over time we'll have to be having pandemics and the other conditions that will need these PPEs. And then motivation for frontline staff. You'd realize that tax incentives were given to healthcare workers, and then some extra benefits were promised by the government for those who would be at the front line. The bigger question was the lack of clarity on who actually is a frontline health worker. So some workers who are in the periphery, for instance, if I'm in the health center, I see patients, and relatively, since the rural areas are not the epicenters of the disease compared to Accra, there's a tendency not to actually adhere to strict protocols, and you may get infected. At that point, are you a frontline staff? Would you qualify to get the incentive for frontline staff? So these are some of the challenges that we've been facing since the introduction of COVID-19 in Ghana.
So with all these challenges, and I might say they are very immense, and with our already struggling healthcare system, I don't see this being sustainable long term, because you mentioned a number of issues where people not even turning up to hospitals for their regular checkups. I mean, these are going to have dire consequences for those individuals and our healthcare system as a whole. You mentioned maternal health declining and all those kind of things. So are there any changes that we are making to our healthcare system to help us address the impact of some of these challenges going into the future?
Okay, so I would say we've adapted, and as healthcare workers, we've made some modifications. We've tried to change a few things just to reduce the burden of this disease and also put us in a position to actually curb the spread of the disease. So mainly through improvising and working with local authorities and facility authorities. Most facilities have developed local protocols for management of the disease. Outpatient facilities, for instance, have been redesigned just by rearranging of chairs, getting more plastic chairs, finding ways to just create the needed physical and social distance between patients, so that those who come in will not have the usual overcrowding where one person sits just next to the other. We are also, as clinicians, trying to really segregate our patients. So we would have those who need like quarterly reviews. Like at first, would have our patients come in and we'll say, we'll see you maybe in a month, or we'll see you in 2 months. But now, depending on your situation, for instance, if you're a man with a BPH, you don't have any severe urinary symptoms, we could schedule you for your next visit in 6 months. So we are looking at really scheduling people according to the degree of their disease. And people are having reviews quarterly, half yearly, and some even yearly, depending on their situation. We are also, as health workers, leading even corporate drives to raise funds to support the management of the disease. And of special mention is the Ghana Association of Doctors in Residency, which has led a drive engaging with several corporate bodies to raise funds for N95s, face masks, gowns, and all that to be used in the management of this disease. And we haven't also just localized our efforts in the facilities. So doctors more than ever are now leading local and national advocacy on TV, on radio, just to create the needed sensitization of the citizens on this disease. And then a few private hospitals are now looking at remote consulting or virtual medical practice. There are a few other private entities that are also looking at virtual medical consultations, like Medical Hub, which I had, just to ensure that we can have an innovative way of seeing patients, addressing simple issues without them coming together and being overcrowded, and people spread the disease.
Yeah. So we're gonna go more into telemedicine in the next few minutes. I just wanted to find out if Nana Kofi was still with us, if he had anything to add to the discussion so far regarding the impact on our healthcare system. Okay, it appears we don't have him with us. But Edward, is there anything you want to add to what you've heard so far from?
Not much. I mean, it's very informative. A lot of information for our listeners. So it's a good piece of information that we received. It seems to tell that we are not getting the real story from Ghana, and people are not really paying attention to things the same way that happened in the United States, where people didn't pay attention, and now we are kind of stuck. So that is one thing that I'm very happy that we actually brought our listeners to appreciate, that that there's a lot to be done. We are not there yet. It hasn't gone anywhere. It's still around.
Yeah. Thank you, Nana Kofi. So I wanted your take on the impact on our healthcare system and the changes that we are making. So Pius has given us a few of the changes that have taken place in the healthcare delivery. He's mentioned reducing crowding at the outpatient facilities, and the last thing he ended on was the use of telemedicine, which we'll get into, in the next section. But there's a question that is directly to you before you go on to talking about this. It says, Nana Kofi, in your research, which West African country would you say has done a good job keeping track of the cases and collecting robust data? Now, this comes from Wisdom.
Yeah, that's a good question. To be honest, I think early on, Senegal was doing a pretty good job collecting data. They had a pretty well thought out data management and data communication strategy. And they created an infrastructure to do that work. The reality, though, is that that's very relative, compared to what we're seeing elsewhere in the world. Because all across West Africa, the challenges are similar. The reason why we don't have good data on beds and deaths is because we don't have good infrastructure for data collection around those things. The reason why we don't have good data on health records, our challenging health records, is because we don't have good infrastructure around that. So those chronic problems, being problems all around the region, make it so that you can say someone did it better, but it doesn't mean it meets the standard that it should be at. So I think in West Africa, really, the leaders have been Senegal and Ghana. But at least Ghana, I'd say March to June, July data collection, when we had contact tracing effective, when we were doing community screening, that data is pretty reliable, and it was based on 4,000 tests a day. So you're getting about 30,000 tests a week and seeing the results of that. That's a big sample for a country like Ghana. So you are getting more consistent information like that. But in Sierra Leone, in Senegal, you start to notice that at some point they hit a 10%-ish positivity rate, and the data there also begins to do its thing. So it's not clear who's really running away with it in terms of like really doing effective data management here. I will say Senegal has as a strategy a better plan than we did, but I think earlier on we executed better. Then you have a country like South Africa who, they are really doing a proper public health response. It's not consistent, it has problems, but relative to what most other African countries are doing, if we're looking for the gold standard for testing, tracing, political interventions, all that kind of stuff, it really would be South Africa right now. But West Africa, Ghana and Senegal would be the leaders.
Okay. Yeah, so it's quite worrying if we and Senegal are the leaders and we are complaining about our efforts. So it shows that I think we're performing under par when it comes to the sub-region. Now going on to the next question. Again, we're still on the topic of the impact on our healthcare system, but I wanted us to talk about something with determining the mortality resulting from COVID. So even over here in the States where the numbers are large, it is even thought that this is an underestimate, and they are using the excess deaths to actually quantify what impact on mortality COVID has. Will we be able to get this data to give us a true reflection of mortality due to COVID? I mean, using that excess deaths, is this something that we have?
So like I was even like kind of touching on that earlier. With the excess death thing, it creates a very difficult problem because you need baseline data. Mm-hmm. And your baseline data needs to be representative, it needs to be done systematically, it needs to be validated. We don't do a good job at that here. I mean, I read a study, a very interesting study about why we start to care about that looked at the recorded causes of death by, like for people who are brought in dead or, are dead on arrival. At Cape Coast Hospital, the reported causes of death and the coroner's investigations after the few cases. And you find that if you look at the coroner's investigation and look at causes of death there, it's a different top 5 from if you look at the actual hospital reports and what the top 5 are. So we know that even in a place like Cape Coast, very small population or relatively small population, even there the data doesn't match up between coroners and between the actual healthcare providers or Ghana Health Service. So the kind of baseline, the problems with the baseline data are pretty large. So to do an excess mortality study, you would need to make quite a few adjustments and assumptions about what the baseline is and whether or not it's representative. And I worry with a study like that, the kind of transformations that's required for just the baseline data, it creates like a lot of systematic error going forward if you get that wrong. So it's a difficult study to do here for sure. But I do think that we have people like Professor Bedu Akosa who are expert epidemiologists. We have people like Fred Binker who are expert epidemiologists who we should be talking to, who can figure out ways to think about this in an empirical sense and can work with people who are working with new methods and new models and other things, figure out ways to actually turn that into proper investigation. But the circle of people who have to be involved in those things has to be much bigger than this now. And if we're going to do that, I mean, 2020 lost opportunity. So 2021, what can we do now? And if in 2020, because of, like Dr. Sanders said, many of the health system pressures, we were also then not getting good data because people weren't showing up and weren't doing autopsies and all that stuff. Then obviously, 2021 will have the same problem with a bad baseline in 2020. So it's a difficult one, but it's something that it would be very critical information to know because, like I said, South Africa did theirs and found out that the mortality was double what they thought it was. Russia did theirs and recognized that it was 3 times what it was. And in those countries, that's actually picking up not just, it picks up some marginal addition to the people who are dead that you don't know from COVID. But what you're also picking up there, like Dr. Sandra was saying, is people who are delaying care because with a heart condition, kidney disease, liver disease, who are then coming in critically ill in the ER and other things, and unfortunately passing at home. Those people are also being picked up in excess mortality studies. So as to what that would be in Ghana, where we already have bad baseline data collection, it's really hard to tell. But I would imagine if we did an excess mortality study, I mean, we would be in for a very rude awakening as to whether or not it is the case that, under 400 people have died of COVID-19 over the last almost 300 days.
Yeah. So we have a comment from Ruth Restayande, and she says it's crucial that we quantify these secondary impacts of the pandemic on our healthcare delivery systems and the general health and well-being of Ghanaians. These outcomes are very important. Emphasizing them in our public education could help dismantle the idea that mortality alone should determine how much seriousness we place on the pandemic. Yes, so that's a very important point. I mean, and our panelists have really emphasized this point that don't just look at it from COVID. I mean, and what COVID is doing to the individuals who contract COVID, but what it's doing to our population as a whole. So let's take a quick commercial break, and then we'll be back with more of this discussion.
Spain has surpassed China related to this virus and the outbreak.
It no be wanna photo, say we dey fight corona. But as we dey take precautions, I get the feeling, say we go overcome 'em.
You know be wanna photo, say we dey fight corona. As we dey fight, we for pay attention, yeah.
Before you sanitizer, for once for seminar, and regularly drink water.
If you coughing or sneezing, nose masks be the new anthem, my guy. Yes, I wear anthem.
Charlie social distancing to the hill.
Stay home be the best option, really, yeah.
Exercise the body and eat healthy.
And at the end, we for pray to the Almighty.
Corona, identity a banaba, but we for take responsibility and keep fighting with positivity. Never spread calm, not fear.
Welcome back, viewers. This is the Health Info Africa show, and then today we've been having a really wonderful discussion. Our discussions have been on the COVID-19 vaccines. We've also talked about the impact that COVID-19 is having on our healthcare system, and we've looked at the numbers for COVID-19. Two panelists with your regular host, myself, Daniel and Edward. These are Nana Kofi Kwachi, who is a public health expert who has been studying what the impact of COVID-19 on our healthcare delivery system is in Ghana. We've also had Dr. Pius Sando, who's a medical practitioner with experience in public health as well, who has also given us some insight into what COVID-19 has done to us as a country. And in this next part of the discussion, we're going to be talking about some of the changes that we are adopting or we have adopted to help deal with this pandemic. Welcome back. Edward, can you hear me? Is there anything before we bring our panelists back on for the next part of this discussion?
No, I don't have much to add, but then I would say that I would like to thank Nana Kofi, who has to leave us at this point, for all the very important, data that he's brought out there. Numbers don't lie, right? We can say all we want, but the numbers don't lie. So we would like to appreciate you for stopping by today. We would like to see you more times whenever there's any changes in, any trend we see in Ghana as well.
Yeah, thank you very much for having me. It's a great pleasure. And like I said offline, I think this is a fantastic thing. You pointed out already that a lot of the COVID conversation is not really critical analysis. It's not focusing on the things that matter. And it's not really in the media attention right now. So I think, platforms like this, opportunities like this to have candid, intellectually honest conversation about what's going on are really the things that are going to help us in changing or averting, a real crisis that's coming our way. And I also think that it's just fantastic that, obviously having young people involved in it and driving it is really something that's happening, because it's, again, long-term outreach that we're thinking about here. So, I mean, thank you so very much for having me. Great pleasure. And I'm happy to be on anytime I can be helpful.
All right. Thank you.
Thank you so much.
My pleasure, guys.
Yeah. Okay. I believe we have Dr. Sando with us. Can you hear us? Pius, can you hear us?
Yes, Daniel.
Yes. Okay. So Nana Kofi had to leave. So from now till the end of this discussion, it's just going to be the three of us. So moving on to the next part of the conversation, which you had already begun. Talking about telemedicine. That is where I want us to take the rest of the conversation now. So what actually is telemedicine for our viewers who have no idea what this is? Now, what has happened here, or what even I saw here in the United States, is that when the pandemic started, we had a lot of hospitals, right? A lot of care providers switching to just virtual hospital visits, right? And then this was really a fantastic idea over here. But then the question that I was asking is, how are we going to be able to roll this back home? So can you briefly explain what telemedicine is and how we've been able to apply it so far in Ghana?
Okay. Yeah. So telemedicine is just simply explained is the use of virtual platforms, and that is using video, using audio, or even messaging to interact with patients, to come out with a diagnosis, and then to advise them on some lifestyle changes, and also to find an appropriate way to provide some recommended medications to solve their health problems. Simply put, when we talk about a consultation, it's just a conversation between a healthcare provider and a patient to elicit information. And based on that, you form a working diagnosis, and then using that, you provide treatment. Traditionally, we've all kind of have a mindset that you need to be in the consulting room, be there physically, see the doctor, and then the doctor provides a diagnosis and then looks at treatment. But evidence shows that it's possible to use technology or leverage on technology to achieve the same thing. Now let's look at other contexts. Even prior to COVID, in developed countries like the US and the UK, they were using telemedicine to a large extent, with some hospitals reporting using it about 10% of their patients. So it's not something that is totally a novelty as a result of COVID-19. In the developing countries, it's been there for a while, and they are now kind of even strengthening it more. And since COVID started, when you look at the United States and the UK, for instance, now for their outpatients, they are using telemedicine to cater for about 80%, and some even facilities about 90%. So you are scheduled and then using an electronic device and then internet, of course. You communicate with your doctor, and then an appropriate medical solution is found for you. So currently, it's something that's in vogue, and the developing countries is the way to go. And even though the developed countries have moved on, have put in strategies, they have strengthened it, we in the developing countries should also look at how to embrace it and how to use it in our context. To know that with the introduction of COVID-19, it cannot be business as usual. We cannot do things the same way that we used to. We need to embrace technology. Just like we use banking platforms, are able to transfer money using a banking application just within minutes. We can use telemedicine to actually seek help from a healthcare provider. Eventually, use telemedicine is cheaper because you avoid the cost of transportation, You avoid the inconvenience of moving out. You avoid even having to get to a place where you would have to crowd and be in a queue with all the waiting time and everything.
Yeah.
All these not come into play when you are using telemedicine. So it is also very, very efficient. For instance, in our example, within minutes of placing a call or notifying us or even testing us, our system is designed such that we immediately can contact you, we can call you, or have a video conversation, and right away we identify what the problem is and we try and solve it. So we are using this digital service to actually address a big gap as a result of COVID-19. As I indicated, many people are scared of going to hospitals. People who are supposed to go for refills of their medications are anxious about going and waiting and being in queue and crowding and everything. And with this service, we are able to address their needs in real time and efficiently.
Great. Thank you for that information. So how has the general public received this telemedicine that your group is trying to introduce? How have they received it?
Okay, so I would say, our society is quite conservative. In fact, it hasn't been easy, and especially introducing such a new concept or an innovation. But with time, it's catching on. So when we started, for instance, typically in a week, would have maybe about 3 clients would need our services, but we've evolved so that now, currently, in some weeks we have as many as 10 new clients who need our services, need to talk to a doctor, need to talk to a specialist in a particular field, and we try and make sure that within the shortest possible time, they have that opportunity to talk to the requisite professional. So it hasn't been easy. I would say we are growing, we are learning, the numbers are increasing. We've also had to invest in advertising using electronic platforms to actually advertise our services. We have broadcasts, messages to the general public. We also share adverts, leaflets to the general public using Facebook, Instagram to advertise our services. So far, these are the avenues we are using to advertise our services, and it's catching on pretty well. And we are looking at it critically and trying to fine-tune it each day to make it more convenient and meaningful for our clients.
Okay, Dr. Sandra, I have a question first. Can you hear me? I have one question. So am I wrong to assume that telemedicine is going to mainly be adopted by the younger generation? Is this the case? What are the ages you realize taking on this telemedicine?
Okay, so from our experience, rightly as you put it, most of our clients, I would say about 80% are below 50 years. So clearly, you see that the majority of our clients are actually young, like below 50. And even with the older patients that we have who are above 60 and 70, most of them were actually signed onto our platform by their children or younger people who get to know our services from the platforms that I talked about. So we are looking at being of service, being relevant to everybody, to children, to teenagers, to adults, and even to the elderly. But we are seeing that probably because of the need to use technology, probably because of the need to use smart gadgets and use internet and all that, and probably because advertising using electronic platforms and social media platforms, our clients are mainly young people below the age of 50. But we are redesigning our module, looking at how we can reach people in all age categories. What we have done is to introduce a home service as well. We know that during these times, especially for the aged and those with pre-existing conditions, it may not be advisable for them to get into overcrowded places or get into even hospitals because of the risk of acquiring infections and even COVID-19. So we are trying to a large extent to bring even these services to their doorsteps. With both the virtual platform and even the home services that we've brought on for this category of people, we are trying to ensure that people do not contract COVID-19, do not have to come to the hospital unnecessarily. So we brought on that platform as well to reach the older clients that we have. And so far, it's been positive. We are looking at how to expand it as well. Yeah.
Okay, so one other question is how it also appears that rural folk are going to be cut out when it comes to these services. Am I wrong to assume that is the case? That rural folk are going to be cut out of these services. Are there any provisions to make sure that they can also access some of these, new services, which would, provide them healthcare in this era that we find ourselves?
Okay, so from our strategy, we aim to provide services to everyone, from the newborn to the elderly, for the poor, for the rich. We are looking at reaching those in the slums. We are looking at reaching those in urban areas. We are looking at reaching those even in the rural areas. So our strategy is not necessarily designed to favor those in the urban or period areas. But what we've seen from the clients that we have so far, they are predominantly from the cities. We have close to about 90% of our clients being from Accra and Tema, and a few from Kumasi and Peoples. We don't have clients from the villages or the rural areas. We've been brainstorming on what could contribute to this. Of course, the only factors we right that again is the fact that you need a smart gadget. You probably also need internet, and you would understand being in a rural area and having to spend CD on Kinky for survival versus using it to buy data or getting Wi-Fi. That may be a challenge for them. But all the same, we are looking at how we can reach everyone. I'm sure if we should embrace other means of advertising, like the radio or like the TV, but of course, those are very expensive platforms. We probably would be able to reach those in the rural area. And let me also put on the record that whilst most of our clients prefer videos that they can have that interaction with a doctor, there's also the opportunity to have just a voice call. So just calling the number will be issued to you of the specialist that you have to talk to. And I think it's quite convenient for those in the rural areas to reach professional medical givers. So we are looking at how to really reach those in the rural areas. But currently, our clientele is mainly those in the urban areas.
Great. So that begs the question that have you received, because this seems to be like something very, very good for our Ghanaian people. Have you received any support from either the Ghana Medical Association or the Ghana Health Service or any government agency in this sense?
All right. Yeah, so we've had our registration done. We have our certificate of incorporation as a company. We've gone through all the paperwork that has to be done. At this point, we haven't had any challenges working with any of these regulatory bodies. For GMA, we need our healthcare professionals to be registered and in good standards. And that's one criteria that is very important for us. We look out only for healthcare givers, for doctors who are certified, qualified, competent, specialized in their area of care, and more importantly, in good standards. So since this is a new year, from next week, we would ensure that all doctors who are on our platform, for instance, have their registration with the Medical and Dental Council done and are in good standing, and therefore can provide this service. So we are looking at all the quality aspects because it's healthcare and it has to be really top notch. Whilst we are providing this service, we need to also have a window for referral of our clients. So we need to really understand the conditions that our patients are presenting with. We need to quickly identify if it's something that is an emergency, and then we have even hospitals that we've talked to, and we can refer people to these facilities or the public facilities. Yeah.
Great. Okay, so we have a question from Ruth Presley, and she says, this is a great innovation. Given economic disparities and digital divide, in what ways can we address the equity for rural and urban poor sections that will introduce telemedicine solutions? What long-term plans can be made to increase access for these communities? I mean, you've spoken to a bit of that. I want you to take this again, but I also want to add on to this. Also, it appears that this is mainly for the private healthcare sector, right? Are there any plans to incorporate it into our public, healthcare delivery system? For instance, where it comes to the point where national health insurance and all those things will come into play. Because moving forward, I see this as an important component of healthcare delivery. So, what do you have to say to this?
Okay, so addressing the question, yeah, we do understand the economic disparities. We do also understand the digital divide, those who have all the modern technology and those who don't. And our services are tailored to actually for instance, we have a package for students, people who are in school and people below the ages of 20 who are subscribing to the service, for instance.
I think we're having some trouble with Dr. We're having some trouble with Pius's feed. We'll try and get him back on. I think we have him. Yes. Yeah, we have. Yeah, Pius, you can go on. Okay, I think we still have some issues. Edward, can you hear him?
Yeah, I can hear him.
Okay.
But I think his feed is gone. But let's continue the conversation. So this individual, let's see when we get him back on. But before we do that, the question was about telemedicine and what plans do they have and all of that. Pius, are you on there? Okay.
Okay, so let's take a comment from Eunice Cromwell. She says, telehealth has been around for years in the United States, but it wasn't until the coronavirus disease that it became regularly used. The growth of telehealth was fueled by the inability to see patients in person at the beginning of the pandemic, and has now been a normal and a more encouraged practice. Yes, I mean it's in these times would promote telemedicine, because I think it's a strategy that can even help us to address some challenges that are not even related to COVID. I mean, going to the hospitals and at this point you have a smart device, you can just sit at home, log in, have a chat with your medical practitioner, and then you can have some of these solutions. And I believe it is something that we should have a lot more health practitioners and a lot more systems getting into. And if it's taken on as a more nationalistic approach, I think it will significantly improve healthcare delivery.
Yeah. And I mean, when she says it's been going on for a long time, I think it actually has been going on even in Ghana for some time. Because a lot of the time, if you're in a family and you're the medic or whatever, people call you on the phone and they ask for treatment or some kind of medicine they should buy. The only thing is that it hasn't been something that is in the mainstream now, and trying to push it into mainstream so that everybody benefits from it. Use some kind of video calls and things like that to add to it will really help us in that regard. But yeah, I think we are running out of time. We're almost 15 minutes. above time, and it's time for us to wrap up the show. But we'll answer any question that anybody puts in the comment section later on. But then this is the time that will allow us for today's show. Dr. Afusan, if you have anything else to add before we wrap up.
So again, I'll go back to everything that I've been saying about COVID. I want to end by talking about how we should keep ourselves safe, keep ourselves protected. I mean, we know them. We've been talking about this since March. Wear a mask, avoid crowded places, wash your hands regularly, use a hand sanitizer, and then treat everybody as a potential carrier. In that case, we're going to be able to protect ourselves. So yeah, that is what I want to end on. I think we have lost Pius again, but
yeah, that's fine. That's fine. So we'll continue the conversation next week, the same time. We will send our flyers out there. Please like the video and share it. If you have any question, if you watch it later and you don't, you want us to answer it, just put it in the comment section and we will respond to your questions. So until next week, is coming from the headquarters of HIA, myself, Dr. Ofori, and Dr. Afosa. Bye to everyone and enjoy the rest of your year.
Spain has surpassed